Welcome back to Mayo Clinic Radio. I'm Dr. Jake Strand.
And I'm Tracy McCrae.
When prescribing a medication for you, your doctor considers many factors, including your age, sex, weight, and current health conditions. Now you may be able to add to your unique genetic characteristics to that list.
Do that line again, please.
Now you may be able to add your unique genetic characteristics to that list.
Pharmacogenomics is the term used to describe the use of genomic information to help select the right medication for patients. The right drug can mean maximizing the treatment benefits or, maybe more importantly, avoiding harmful, sometimes life-threatening side effects. And here to discuss that are Dr. Timothy Curry and Dr. Michael Stevens. Dr. Curry is the Education Program Director and frequent guest here at the Mayo Clinic Center for Individualized Medicine. And Dr. Stevens is the Chair of Pediatric Gastroenterology at Mayo Clinic, who had pharmacogenomics testing done and received some surprising results. Welcome to the program, both of you. It's nice to meet you.
Thank you.
Yep, thank you.
Dr. Curry, how many times have you been here? Have you lost track now?
I think this is my third or fourth time, and it's a wonderful experience every time.
Well, pharmacogenomics, definitely something that people are interested in. And why is it so important? First of all, tell us what it is.
Sure. Well, so pharmacogenomics is understanding or the study of the genetic information related to medications. And it can be everything from how well they may work in your body, particularly how they might interact with other medications, or maybe avoiding really severe side effects. And I think that's what we're here to talk about today.
Exactly. And Dr. Stevens, why don't you tell us how and why, what you learned? Tell us a little bit about your story.
Well, my research interest has always been included pharmacogenetics and genetic testing. And a group of us at Mayo were able to have whole genome sequencing. It's mainly people that were interested in genetics.
Benefit of the workplace.
Exactly, exactly. As it turns out, there was a pharmacogenetic finding in my sequencing. They found a variant in a gene that is implicated in a reaction to general anesthesia that can be life-threatening called malignant hyperthermia.
Goodness. All right. So
Good catch.
Yeah. Very important catch.
Very important catch.
All right. Dr. Curry, tell us what the right 10K study is. What does that mean?
Sure, and this is sort of related to the same subject, but the right 10K study or the right protocol is a study looking to figure out if we put this information in the medical record, how would someone like Dr. Stevens benefit from it down the line? How would our health system in general and how would our health care and wellness ultimately benefit? So what we're doing is we're looking at about 10,000 participants in what we call the Mayo Clinic Biobank who have agreed to let their samples be used for DNA sequencing, putting that information into the medical record and having it be there for individuals or physicians, prescribers, nurses to be able to use to help guide their patients' care.
And so this kind of maybe combines the two together. I'm fascinated. So when you got that information, what did you do?
I called up my friends who are interested in pharmacogenetics to find out if this really was something that I should be worried about. In the end, it was reviewed by the anesthesia group in the Center for Individualized Medicine, and my pediatrician referred my daughter to have genetic testing to find out if she was at risk for this, and it turns out, happily, she's not.
Yeah, and that seems like the important piece of this is how do you take that information and then put it into practice, both for patients and then also speaking as a physician who gets these reports sometimes. What do we do with that information?
It's a little bit ironic that, Dr. Curry, you are an anesthesiologist, and this is a potential hazardous situation that could have resulted if you had undergone surgery. What might have happened?
Yeah, and in fact, I was the one that got that phone call, and I was the one that was able to put it in the medical record. So next time you do have surgery, that in our system, it'll pop up. But of course, there's other places where you may need to have that, and people need to take that precaution. So malignant hyperthermia is one of those words that gets an anesthesiologist's attention. It's a potentially fatal problem, and it's a problem with one of the receptors that deals with how calcium moves into the cell. So on a cellular level, calcium is what causes our muscles to contract. And with this mutation, when their cells are exposed to certain drugs, general anesthetics, the gases that people talk about when they breathe them, or certain drugs used to relax the muscles, it can cause uncontrolled calcium release, which causes uncontrolled muscle contraction, which causes very, very high fevers, high heart rates. The body essentially begins to burn itself up within. Now, we have a specific antidote for it. That's the good news, and we're always looking for this. But if we know about it ahead of time, it's very easy to change our medications and use ones that would cause or result in a safe anesthetic. It's well known here at Mayo Clinic. This used to be one of the testing centers. There's a confirmatory test, and there's actually a group up in the Midwest, particularly in Wisconsin, that are susceptible to this.
Well, what if Dr. Stevens is someplace that if he's traveling or something happens, are we going to be at a point where his genetic record, his pharmacogenomics record will go with him wherever he goes? At this point, that's not a possibility, is it?
So the organizations that really focus on this problem will recommend that if it's a personal choice, but you can wear a medical alert bracelet.
Oh, sure.
And you carry that with you, so you always have that in your records. But I think, and this is what HIPAA ultimately, it's the Portability Act, was the portability of healthcare information. That was a big part of that, because that's one of the problems right now, is when you go somewhere else, you don't carry that information, and it can be challenging to be able to do it. And it's not just in anesthesia, it's in everything, in all of our medications. And hopefully with the integration of all of our medical systems, that's what we'll see.
So when I think of pharmacogenomics, I think of the medications that people are taking. This is a surgical implication that I would not have considered. Or is there anything else that I'm not thinking of, medications or surgery, any other reason that your genetic profile would make a difference?
We'll use this a lot of times in your care as well.
Right. We use this in the care of very young children with inflammatory bowel diseases. So my specialty is Crohn's disease and ulcerative colitis. And there are over 200 genes that are connected to those diseases for maybe the typical patient. But it's the atypical patient that we're really interested in, and where genetic testing seems to be helpful. So children who develop these problems under the age of 6 often actually have much more rare genetically caused diseases that mimic things like Crohn's disease or ulcerative colitis. And so we're doing genetic testing to try to identify those diseases and find a more specific answer for that individual.
And I guess I'm curious, what percentage of patients have actually had this done? I mean, so if you're seeing this with young kids, we're seeing this with people who were part of this original kind of sequencing, how many people are undergoing these tests?
At least in the realm of inflammatory bowel disease, it's probably a minority of patients, and we're really focusing on the patients where we're most likely to find a specific answer.
So you're starting with the kids you said younger than 6 that you're doing that with?
Very young patients,
Sure.
And then other kind of unique situations. Another example is families where multiple generations are affected. That's generally unusual for Crohn's disease and ulcerative colitis.
Other people who are ahead of the curve, I guess, on genetic testing, Dr. Curry. So we've got the people who were in the biobank study.
Yep.
I'm in that. Are you in that, Dr. Strong?
I don't think I'm in that
Yeah,
study.
you got to get in there. I get all kinds of cool information from that study. Where else?
So I think pharmacogenomics is where you're going to see most of testing early on, because that makes the most sense to most providers along the way. When we do these exploratory sequencings of the whole genetic diversity of the human, it's really challenging. For example, you find out things that you don't know the answer to. So some people end up having a mutation in the receptor that we don't know if it's a problem or not. And so it gets really challenging to do these sort of exploratory studies, especially when you're not looking for something and you get it. However, if you're doing studies on how your genetics affect medications, we're getting to the point now where we can provide concrete information, concrete recommendations in the forms of reports and in the forms of consults. And so I think Mayo Clinic and the Center for Individualized Medicine sort of vision is that everyone will have that information available, and that the pharmacists and the physicians can use that information to help prescribe medications at the time that it comes, not just in response to looking for a problem, but trying to prevent problems down the line.
And we're going to talk a little bit more about that. We have to take a break. We're discussing pharmacogenomics with Dr. Timothy Curry from the Center of Individualized Medicine and Dr. Michael Stevens, a physician who took part in pharmacogenomics testing. We're going to take a short break.
When we come back, we'll discuss the future. Will this type of testing become a standard part of care? Welcome back to Mayo Clinic Radio. I'm Dr. Jake Strand.
And I'm Tracy McCrae. We're back talking about pharmacogenomics testing with Dr. Timothy Curry and Dr. Michael Stevens. So, Dr. Stevens, what was it like when you talked with the rest of your family? You said you had your daughter tested, but what was that conversation like for the rest of the family members?
It was somewhat alarming to my wife to hear about that, and I think between the two of us, she's maybe a little more of the worrier. It hadn't dawned on me that we probably should have my daughter tested until I talked to my wife about it. That we also found that I was a carrier for some very rare diseases, as most people are, and that was kind of interesting.
Not that you've ever had, but that just are there.
Right.
What
right.
about any siblings or parents? Did you have any other family members tested?
I did not, and I'm in a little bit of a unique situation because I'm adopted, and so I don't know a lot about who I'm genetically related to.
Gotcha.
Yeah.
All right, Dr. Curry, as we go forward now, and this becomes something that at some point everyone will have a little category of our record, what implications will that have? It'll, of course, make healthcare better, but talk a little bit specifically about the medications that we'll be taking.
So it'll make healthcare better if we can have the information in our workflows and we know how to use it. And that's what my role is as the education director for Individualized Medicine. It's my job to make people aware of what this information is out there, but also to understand how to use it in their care. When's the right time to use it? When's not the right time to use it? And when do we need to consider other factors that are not genetically related? And as we gain more knowledge about what this information means, we'll be better able to do that down the line.
So when we think about that piece of it, how do you integrate that? What sort of training do physicians need to have to figure out how best to use this information?
What we're starting with is going back as early as we can, back into even into the grade schools, but really in the medical school level. That's where you start, and those are the individuals that are going to be bringing that information forward and helping us down the line. But everyone needs to understand where the information is, when to use it, how to use it best, and how to use it to explain to their patients at the same time what this means to their healthcare.
I'm sorry, go ahead.
Oh, yeah, I was going to say, I had actually a patient walk into my outpatient practice a couple of weeks ago with a report from a commercially available company. And so I'm kind of wondering, so is this something that people are paying for out of pocket? I mean, this person did. Are some people getting this covered by insurance? What's been your experience in the landscape here at Mayo?
So you can get it here at Mayo Clinic. It costs about $250, and more insurances are starting to pay for it. You obviously want to check with your specific insurance company ahead of time to see if it does. But people are now starting to pay for it out of pocket even because they realize that it's something that could help. There are lots of companies that are starting to bring this forward, and that's one of the challenges as a physician is understanding what each company's testing is, how good it is, and how to interpret the reports that they're bringing to you.
Is there any way to standardize those? I mean, I cannot tell you the number of relatives who had this done as a Christmas present. They were giving this as Christmas presents last year. And so each of them come with a different, angle on why they're having this testing done. But is there any way to standardize it so that it's all kind of telling us the same thing in the end?
We run into this problem throughout medicine. I mean, you get x-rays from other places or lab reports, and it isn't standard. And that's one of the really hard parts about, especially at a place like Mayo Clinic, where a lot of our patients come from somewhere else, is understanding how to use this information. So standardization is good, particularly the knowledge base behind it. And there's lots of groups that are really trying to help get the education out there for people to interpret it, both when it is standardized and when it's not.
Well, let's say that you have listened to this interview and it's been so inspiring to you that you want to go and you want to get the testing done, just specifically so that you know for your medications, because right now you could be taking medications that would be affected by the information that you would find through the genetic testing, correct?
Yep, and the place to start is with your physician.
Right.
You need to go and have that conversation about what is the right thing to do at this time. Is this and learn a little bit more about it. What are the implications for your family? I mean, I think we heard very interesting comments here. Whether you're adopted or you're not, there's lots of implications for talking to your parents and your siblings about this. But that conversation has to be decided of what the testing is going to be and how we're going to use it going forward. And that is it's a shared decision. We hear a lot about that in medicine now. That's a decision that you, your physician, your provider, to be able to do that, so that when you do get that information, you've got a plan on how to use it going forward.
I know that one of the things that people are concerned about, maybe worried about even, is when you ask if insurance is covering this, if insurance companies want to have their fingers in it so they can see what your genetic makeup is. And people are concerned, what if I find out, as you said, that I've got, a propensity, or there is in your genes that you could get a serious illness. The insurance companies are not finding that information out, however.
Well, it's in your medical record, and so it's out there, and something we need to think about. There are laws that are out there. There's a Genetic Non-Discriminatory Act that the United States, not everyone is followed under that, so if you're in the military, you run into a different set of things to consider. So that information isn't supposed to be used against you in your gaining insurance down the line, but there's still a lot of conversation about this, and so what we call the ethical, legal, and social implications, we call it ELSI. That's a really important thing about having these conversations, and that's why it starts with a shared decision. And I'm sure you see that in your own care
right.
too.
And that that's a part of when we're doing this type of testing on my patients. we involve a genetics counselor to talk about that. And you kind of alluded to this a little bit. You know, it's possible you may find information that's predictive of things that may happen to you in the future, and not everybody wants to know that. The classic example is a disease called Huntington's chorea, which is, we really don't have a treatment. It's a devastating disease, and it typically happens in your 30s or 40s.
If your genetics, if it's in your genes, it doesn't mean that it's going to happen, though.
Well, that's an example where there's
Usually
a very
will.
high likelihood that that's going to happen. So that's a unique and kind of the most extreme example of that. But it needs to be discussed and a part of the decision-making process.
I know,
So
I'm sorry, go ahead.
So some of these tests are very specific, and that's things like pharmacogenomics. But as we start to get into cheaper sequencing in general, where you're starting to look at the whole genes, all the genes, the whole genome sequencing that you went under, these conversations are going to be more important because people will have the decision to make, do I just look at something that I want to know about, like for drugs, or do I want to look at everything? And the drugs will be in there, but I'm going to learn some other things about myself I may not want to know about. It may have something to do with Alzheimer's, it may have something to do with cancer, or it may have something to do with a devastating and untreatable disease.
So I know in the past when you've been here, Dr. Curry, one of the things that you're working on is how to train physicians to look for this information. It's one thing to have it in your record, but another thing, as I was sharing with you before we got going, the last time I got a prescription, I asked my doctor, can you check? Because I was in that biobank study, so I do know that there are, I'm an over-metabolizer of some medications and an under-metabolizer of others, and she hadn't even thought to look there. And sure enough, it was a medication that was affected. How do you teach a doctor, doctors, how do you teach a doctor to look for that information?
Well, one of the ways we do it is we
habit?
put it into their workflows. And I think that's one of the most important things. So, for example, now when I open up Dr. Stevens' preoperative records, there will be a pop-up that says risk of malignant hyperthermia. And we're using other clinical decision support at the bedside to be able to hit the same things. I think you use some of that in some of your practice too.
Right. There's a group of medicines that we used to prescribe quite broadly for Crohn's disease called thiopurines, and people can have a pharmacogenetic risk to have bone marrow suppression with that. And that Mayo incorporated that, I've never seen this anywhere else, into our electronic health record, that every time I ordered that test, it asked me what that patient's genetic result was, so that it would prompt me to look at that.
And I'm curious, with kind of building on that same question, so if you're an over-metabolizer or an under-metabolizer, what does that actually mean for how that drug is going to work in you? So what studies are ongoing to help us better determine that?
So we're doing lots of different studies now throughout Mayo Clinic. Some of them are in the pediatric gastrointestinal disease clinic. Some of them are within surgery to try to find out if you burn through a drug or over-metabolize a drug too quickly, will you not have enough of an effect? Or if it's a drug that gets activated by those enzymes, could it have too much of effect? And there's a classic example of that with codeine. And if certain individuals metabolize it too quickly, they may have too much codeine in their system that gets turned into morphine, and they can have really serious side effects, including slowing down their breathing. And so those different things mean different things. And that's the hard part.
Right.
So under and over are not so simple along the way. And that's why it really takes having a physician to help interpret these results to be able to understand what the implication is. And that physician needs to understand then, or that prescriber and that pharmacist that's helping, because they're critical in this whole process, need to be able to understand what the implications are for each individual. That's why the reports are nice. They help guide you along the way, but it takes a level of understanding. And that's what education is all about.
We've been talking about pharmacogenomics testing with Dr. Timothy Curry and Dr. Michael Stevens. Dr. Curry is the Education Program Director at Mayo Clinic Center for Individualized Medicine, and Dr. Stevens is the Chair of Pediatric Gastroenterology at Mayo Clinic. He took part in pharmacogenomic testing. Thanks both of you for joining us.
It's our pleasure.
Thank you.